Welcome to the JOMA Preventative Health Podcast, hosted by the Jewish Orthodox Women's Medical Association. We provide you with up-to-date information on health topics geared towards the Orthodox Jewish community. This podcast content is provided for informational purposes only and is not intended as medical advice or as a substitute for the medical advice of a physician.
Welcome to the Jewish Orthodox Women's Medical Association, or JOMA podcast. I'm your host, Elisa Minkin. I'm a general pediatrician and proud JOMA member, and I'm really honored and really excited to be interviewing Dr. Lias Gaggino. Before I formally introduce Dr. Gaggino, I want to say a few things. First of all, I need to give a trigger warning. This will be discussing not just mental health issues, but also suicide, so that can be a very challenging topic and may be a trigger for some listeners. So that's number one. Number two, I always like to say, please reach out to me if you have a topic you haven't seen me cover or you want me to cover in greater depth at health, HEALTH, at joma.org. I'd love to get people passionate about their topics. So please reach out to me. I will say that I think this is a really, really important topic. The basic topic tonight is suicide prevention. It's geared both to what I call regular people who are not healthcare professionals, but maybe a little bit more this time than usual to healthcare professionals. Dr. Gaggino has a program organization that she will talk about called Medical Behavioral Health Solutions, I believe. It's at www.medicalb, as in boy, H as in happy, S as in Sam.com, www.medicalbhs.com, where she gives support to healthcare professionals and systems to integrate behavioral and mental health, which I think is really, really important. So I'm really honored and really excited to be interviewing her tonight. So here we go. Dr. Gaggino is a primary care pediatrician practicing on the west side of Michigan for over 30 years. From 2015 to 2020, she served as the Kalamazoo-based Bronson Healthcare System Medical Director of Behavioral Health, implementing zero suicide practices and building integrated behavioral health in primary care. Knowing that the emotional well-being of children is at the core of their total health, Dr. Gaggino has partnered with other professionals to develop processes and protocols to strengthen cross-disciplinary diagnostic and behavioral healthcare models, and when given the opportunity to collaborate with the other healthcare professionals, has always come to a better, more comprehensive care solution for patients. She is the founder of Medical Behavioral Health Solutions, LLC, offering support to clinicians and systems, and the host of the Pediatric Meltdown podcast, featuring experts on children's emotional well-being, which I have to say, she says it's geared towards pediatricians. It is not just for all healthcare professionals, but I believe anybody can listen to it and learn from it. They are phenomenal. She features experts on children's emotional well-being. She currently sits on the American Academy of Pediatrics AAP Board of Directors, partners closely with the Michigan chapter of the AAP, and is a consultant to the University of Michigan MC3 Child Psychiatry Access Program, which we talk about in this interview. Welcome, Dr. Gaggino. Thank you so much for joining me tonight.
Oh, you're more than welcome. Thank you for inviting me.
Oh, I'm so excited. I'm such a fan of your podcast. I have so much to talk about tonight, but I noticed that you talked about your own mental health struggles, and I think that probably underlies a lot of your passion for pediatric and mental health.
Oh, absolutely.
So Can we start with you sharing some of that story? I mean, I guess a shorter version.
Sure. I'll make it. I'll give you the brief version. So yeah, I'm one of four girls. I grew up in a household where there was significant amount of emotional abuse and some physical abuse, and it really affected all of us in different ways. For me, I'm just like uber anxious. I worry about everything. It's sort of I'm always looking for trouble, and it's kind of like the radar's always up. And if something's not happening, I'm worried that I'm not worried. So, but with lots of therapy, things are better. And we have a close family. There's been a lot of reparations, I think, but, trauma like that affects your brain. And so for me, therapy and medication has been really effective. And I wish I didn't have to take medication for some of the things that I struggle with, but it makes my life easier. And it's kind of like wearing glasses. I don't love that either, but, I need to see and I need to be able to function. And so for me, medication's been helpful, and huge shout out for therapy.
Absolutely. I loved in your podcast how you gave like a whole long list of different things that you do, sort of a mental wellness checklist.
Yeah. So I wish I could say I do them all the time and really well. I want to do meditation, and my therapist really highly recommends it. Doing it for extended periods of time, I'm not that great at it, but I try. But yeah, I think, for me, and if you listen to the podcast that went up today on trauma, really the key to resolving trauma and resilience is affiliation, and that's being with other people. And that's what I do. I have great friends. I love my colleagues. The AAP has been a huge thing for me, connecting with other people who love kids. So, and I think that's why, my commitment to kids is that I don't want them to go through some of the things that I did, if I can help. Right.
That personal experience really is what I think drives you and makes it so real, and so I think that really, really is helpful for people. You're not just coming from like an ivory tower. You know what I mean? You're not preaching. You're there with them.
Well, I'm not fancy, if that's what you mean. And,
it's very different when you're coming from a place of experience.
Well, I think it's lived experience, and it's also, climbing your way out and knowing that there's other things to do. I don't know that I'll ever be like cured from anxiety, but it's manageable, it's tolerable. And I'm fortunate. I'm privileged. I was able to go to college and travel and have a really great job. And I have a fabulous husband, and that was like my best decision ever. And, but there are ups and downs. And you've listened to the podcast with the kids. There've been some eating disorders and stuff. So, just because you're a professional doesn't mean that you get to escape anything.
Right.
It's all there, right?
We're people too.
Yeah, absolutely.
That was actually the first episode was with your daughter about her eating disorder. And that is a phenomenal episode.
Yeah. She's an amazing young woman. Yeah. And she's really very much, has worked really hard to be comfortable in her skin. And, so anyway, she's in Bali, and I am going down there in 2 days to join her for a week.
So nice.
So I did my podcast next week, which will be on June 22nd or something, is on my Bali mental health break. So I'll let you know how it goes.
Can't wait. That sounds awesome. So let's talk about the kids. It's been talked about a lot. We're in a mental health crisis. We really were before COVID.
Absolutely.
And it's so much worse.
Mm-hmm.
So let's talk about that. Let's talk about the kinds of things that kids are dealing with. Just sort of an overview, because we're also going to talk about, this is really going to focus a lot on suicide. It's a really hard topic, but we really have to talk about it. But I just want to put it in the setting of what's going on with the kids.
Sure. Well, I think you're absolutely right. It's not like mental health issues like just created de novo out of the pandemic. I think the numbers were back pre-pandemic, like 1 in 5 kids struggle with depression. I just pulled the youth risk behavior survey, the YRBS. So it's been updated now to 2019. So I'm for those of you who can see me, I'm looking at my notes now. So now the current number, experience persistent feelings of sadness or hopelessness, is now at 36.7%. So 1 in 3 kids are feeling sad and depressed. That's significant. That's a lot of kids that don't feel good.
It's a lot of kids, but I don't think that it's the same throughout the ages. I think as you get older and older, the percent actually rises. And I think that's an average that underestimates how much of the older teens.
Right. And this YRBS is in, I think they do it in, I want to say seniors in high school. So, but what's really nice about this survey is they do it year to year. So there's been lots of data, so you can go back and look at the changes over time. And, the bottom line is kids don't feel good, and they haven't felt good, and now they feel worse.
Right. I don't know if you want to go into why that is that we're dealing with this, or just move on to.
I think I don't think it's one thing. I mean, I think it's multifactorial. I mean, certainly pandemic. I mean, I think we all felt sad and depressed and scared and hopeless, with that kind of isolation. And I think the helplessness part of it. I just think there's a lot of challenges for kids. I do think I had a teacher say to me, we were getting pedicures next to each other. And she said, I have my own theory about why kids are having such a hard time. And she said, I really feel like social media and sort of video, that they're just isolated, that they don't go out and play anymore. So, I don't know what the research is on that, but that connectedness, sense of community. And yet, kids, when you talk to kids that have forward thinking, I mean, these kids want to change the world. They're all into social justice and environmental health and all those things. So, I don't want to get too doom and gloom, because I always think there's hope with kids. I mean, that's why I love pediatrics.
I do. And I think that they have a lot of the solutions, and we have to listen to them and empower them.
Yeah. And they have the enthusiasm and the energy. We just have to support them to get them through, I mean, high school's tough, middle school's tough. I mean, it sucks a lot of the time. And, you're expected to be good at everything. It's not like, like I'm terrible at statistics, but I don't have to do statistics in my life. I have other people that can figure that stuff out for me. But when you're in school, you're supposed to be good at all of it, so there's a lot of expectations. And, I just listen to kids that are applying to medical school now. When I applied to medical school, and again, this was a million years ago, and maybe true for you, I think I applied to 6 medical schools. And I talked to a kid yesterday, and he is applying to 22. I mean, that's insane. That kind of competition, the expectations, it's kind of crushing.
Right. I think that's actually below average.
Yeah. I mean, that's ridiculous.
And apply to several dozen. Yeah.
Yeah.
Yeah. And exactly. So let's talk about getting mental health care, because that's a separate issue. And putting aside that the rates have gone up from already high, why that is, we're not going to go down that rabbit hole any further. What about access to mental health care?
It depends. I mean, I think it depends on the community you're in. If you're in Boston, you've got lots of access to resources. If you're in the Upper Peninsula of Michigan, you've got very little. I think our rural areas are really stretched. And they also, I think one of the advantages of the pandemic has been, access to virtual care, telecare.
Right.
But you have to have broadband. You have to have good Wi-Fi, and a lot of those communities don't. I just think right now our mental health professionals are stretched thin. I mean, I hear long waiting list. I do think the more accessible they are for tele options is helpful. But I think we have to get creative about what are we going to do to meet the needs.
Right. And there's also access in terms of finances, because mental health we haven't achieved parity yet.
Right. Yeah, no, that's absolutely. Well, and I think, if you have Medicaid insurance, you may get services covered. If you have it's sort of one of those things, in order to get really good community mental health services, so wraparound home base, which can be awesome interventions, you have to be really sick. You have to have severe emotional impairment. So that leaves out a lot of kids who have mild to moderate illness. And so getting services. So sometimes I've heard people say, well, poor kids, people that have Medicaid, they can get what they need, so we don't need to focus on them. Well, that's not true. And then you have a lot of private pay kids who can't access resources either. There is no home-based or wraparound services for private pay, at least not in the community I've worked in. So, and then the other is quality of mental health providers. When they say they do CBT, do they really do CBT? Do you have somebody that is skilled in trauma-focused therapies, eating disorders? I mean, you have to have some expertise. So, So I think our mental health system is stretched.
Right. And you do have that company that you made.
Oh,
so
yeah.
I'm going to let you plug it right now because I was going to do it later.
Sure. So
I started some answers for us.
Yeah, I started a private company. It's called Medical Behavioral Health Solutions. And essentially what I can offer is doing an assessment of a practice. Like, what do you have? And, what's your behavioral health services? What you want, what is it that you need? What are your goals? And then figuring out what are the things that you can do to improve the services that you offer. It's important to know about coding. There are lots of different ways to do mental health services. I advocate big time for integrated behavioral health, meaning having a healthcare professional who is a mental health professional in your practice is a game changer. And I've said that on the podcast a million times because it's so important. So I think in terms of thinking about how can I have these services in my practice? So if there are people that are interested in, practice transformation to make it more welcoming or more efficient for providing mental health services, check me out, medicalbhs.com.
Yes, I'm going to mention that. At least another point. Yes, give you another plug for that. That's really important, and that's a really important service. And the other thing we should talk about is programs like the one that you have in your state, MC3.
Yeah. So those are
Project Teach. I think a lot of states have these.
Yeah. So they're called Child Psychiatry Access Programs, and all but 4 states have them, and there is HRSA funding now to support the expansion to all 50 states. And essentially what it is a curbside consult service. It's the ability of a primary care physician or nurse practitioner or PA to call and say, hey, I've got a kid with X, Y, and Z symptoms. This is what I've already done. This is what, I'm struggling with. What would you do? Because we know these kids can't access child psychiatry. There just aren't enough of them around. I mean, we didn't talk about that whole thing when we were talking about access, but, and so a child psychiatrist gets on the phone and we talk through the case and they make recommendations and we initiate, and I can follow up. I can get feedback. I can get support. And what happens over time is I get to be a better clinician because I know, hey, 3 phone calls before they recommended that I use Prozac at this dose. And then the next step would be to, increase the dose or change, so I know the next kid I see with the same set of symptoms, this might be where they would recommend. And it really changed my prescribing practices, to be honest. I just was a better clinician.
Mm-hmm. Did you go through a training program? Because I know in New York, we have a training program. It's like a couple days where they give lectures and they have 6 months where you have phone call conferences.
Yeah. I've done lots of things. So, my training, probably like yours, I did general peds and really, back in the day, what we were treating, and I think pediatricians are good at, is ADHD. But, as far as other mental health training, I really didn't have that. So I had a colleague, Mark Sloan, who's been my mentor, and learned a lot from him. And then I just started taking courses. A couple of things that I think are good suggestions. Mass Gen in Boston has a psychopharm course that is great. I did the Reach Institute, which is what I think you're referring to.
Yes.
And that was with psychiatrists. And then for 6 months, we did case reviews. Mm-hmm. A lot of places have echo services now. So you can do an echo project. We're going to do one here in Michigan. And again, it's small group. You do case presentations, which is how we learn. Mm-hmm. And you have an opportunity to discuss the case. So it's that case review. And then Stephen Stahl through the NEI Global, the Neuroeducational Institute. He has great stuff. I love that. The AAP has courses. The American Academy of Child and Adolescent Psychiatry has courses on psychopharm for primary care. So there's lots of things, and I just availed myself of that because I like it and I think it's interesting and I wanted to be better.
Right. Now that's so amazing. How do we encourage other healthcare professionals to do the same? Because we need a lot more.
Well, it was interesting. I just did a podcast with a child psychiatrist. Her name is Dr. Sarah Muhyiddin. And she and I had a conversation. I thought it was fascinating because I said, I think we get frustrated because we just can't fix this. And she said, we don't think about it like that. Child psychiatrists don't think about fixing. Mm-hmm. We think about how do we help a family manage and strategize. And the other thing she said is we engage in a lot of negative self-talk. I don't like this. I'm not good at it. It's not my job. I didn't sign up for this. I didn't train for this. A lot of negative self-talk. And then that leads to avoidance. Like, I'm just not going to do it. I'm not going to do mental health care. And the problem is the kids need our help. So she really talks about, it's kind of like DBT, learn stress tolerance, learn how to manage your own emotional overreaction to feeling like mental health is stressing you out. And I get that it's hard. I love it. I'm fascinated by it. I think I'm good at it because I like it and I'm interested. It's not because I'm brilliant. I just think it's because I'm interested enough to listen.
I'm going to call out the elephant in the room. How much time do you have to do this?
The podcast?
No. The mental health visits. No, the mental health. The big elephant in the room is the amount of time. Yes. The average visit now is like 10 to 15 minutes.
I never med checks for me. I would do at least 30 minutes in new patient, 40 minutes because we did 20-minute increments. To do a med check in 10 minutes, I don't think you can do it justice. So, and honestly, I just bit the bullet. It was, if that was going to affect my RVUs, then so be it, because I couldn't do the job well. And the other thing is I enjoyed it. There was something about sitting down and talking with patients about their lives, what's working, what's not working, that was gratifying for me. It was rewarding. So I made time for it. And, but I think the other thing is now with the way that you can code for time, you can code for documentation, you can code for calls you make to therapists, schools, your child psychiatry access program, you can include that. And you can include, you can code your 99215 plus 15-minute increments of time. And I think we have to do that.
Right. I think that we learn to code for everything else, and we can learn to code for mental health to make it more financially doable. But I think we also have to value the mental health.
Our parents and our patients clearly want us to. This is where the demand is. Prior to the pandemic, it's like the 1 in 3 reason for kids coming to a pediatrician was for behavioral health concerns. It could be, a toddler who's biting, or a kid who's not doing well in school, or the kid who's irritable or using substances. But it's common. It is what is affecting kids right now. So we have to go there. If you're going to do pediatrics, you have to do behavioral health.
Right. It's not like, not to bring up the COVID, but you can't say, well, I'm just not going to do COVID. I don't like COVID. It's there.
Well, then nobody would want to do COVID, right? Well, and I really like Dr. Muhyiddin's reframe. Like, you don't have to love it, but you have to tolerate it. And you have, but the other thing is you want to be gracious about it. When families need you, the last thing, imagine that you're on the other end. The last thing you want is somebody to be like, yeah, I don't do that. I'm not interested. I don't want to talk about that. I don't have time. How dismissive. Parents, they want us to be with them and kind of ride the ride struggle. I think that there's this idea because that we have to fix it in that visit. And that's just not, you have to reframe that. You just have to.
Right. I think for pediatricians or, healthcare professionals in general, it's so satisfying. You get strep, you get a kid with strep, right? You give them an antibiotic, they get better. It takes 5 minutes, right? And you're done. It feels so good.
Well, and not going to lie, there are days when you have, I would do, sometimes I could have 8 to 10 med checks in a day, and I'm seeing maybe 18 to 20 kids. so half of mine would be med checks. And yeah, it was a relief to get like an easy ear infection. You want to have, I tried doing all just mental health. I couldn't afford it because I couldn't, the pay cut was too much, but, and it was exhausting. It was before we had, mental health professionals in our practice. And, but it's gratifying work. And I mean, there's nothing like fixing a nursemaid's elbow though, right?
Right.
2 seconds and you're like, you're a magician.
It's so true. It's so true. Okay. I really do want to pivot to suicide. It's a really hard topic, but it's so, so important. And I would like if you could just put it in context. How common is it in childhood and adolescence?
Well, it's the second leading cause of death in kids 10 to 24. And it's increasing in number. It hasn't gone down in a decade. And so it's the second reason why kids die. So we have to pay attention to it. Of course, the first reason why now has just changed. It's gun injury. So for our little kids, that's accidental injuries. And for our teenagers, it's suicide. So, these are preventable. I'm not saying every suicide is preventable, but there are so many inroads that we can make to save lives. That's why we go into medicine, right? We go into save lives. So, hey, this is where you can do that.
Right. And when we say suicide, we really should define the different terms, right? Because when we're trying to prevent it, we're looking for thoughts of suicide. Right.
Yeah. So, you have suicidal ideation. And that I think, back in the day when I, first started kind of really thinking about this, probably when we started doing PHQ-9 screening back in 2009, when it came out as a recommendation that we screen for depression, any kid who had any thoughts of suicide, I was sending them to the emergency room and I was calling our psychiatric hospital saying, please take this kid. And of course they didn't. So there's levels of ideation. I mean, there's the kid who, I broke up with my girlfriend last week. We'd been together for a year. I'm so sad. I think about it all the time. Sometimes I wish I could go to sleep and not wake up. But when you start asking, which is where you really need to go, how bad is it? And they're like, oh, I would never think about killing myself. Never. I mean, sometimes it would just be easier if I didn't have to deal with this, but I would never do that. So there's that level of risk. And then on the flip side, there's I can't stop thinking about suicide. I know where my mom's gun is and I'm going to shoot myself. So, but those are that's an outlier in primary care, I think. I mean, I don't know what your experience is, but mine is, I mean, I could count on one hand how many times I've had that encounter in my office. Now, if I'm in an emergency room setting, that's a different story. But to have that acute imminent risk is unusual. But then you've got the kids that are in the middle. They're ambivalent. Those are the ones where it's the biggest struggle for us because there is risk and there's no guarantee that anything you do is going to absolutely 100% guarantee that they're not going to kill themselves. But there's a lot that you can do with that group.
Right. So what would that lot be? In
terms of what would I do with that? Would that look like? So I think the first thing is screening.
Okay.
You have to ask the question and you have to ask all kids. You can't just say, well, it's just kids with depression that I'm going to ask because I've had, and I'm sure you've had the experience. I remember clearly cute 13-year-old, happy, smiling cheerleader for all the world, looked like everything was fabulous. And on her PHQ, she said, yes, she was having thoughts of suicide. And when I started asking her, she had a plan. She was going to hang herself. And I nearly fell off my chair. I had no idea. I would have missed that. So asking, and now it's a Bright Futures recommendation that we screen for suicide using an evidence-based tool. So there's a couple of different ones. The PHQ-9 is a proxy. And the problem is with the question number 9, it's thoughts you'd be better off dead or of hurting yourself. And it's that phraseology that sometimes misses the kids. And so the ask screener ask specifically, are you having thoughts of killing yourself? And that's a different question. The Columbia is also another screen that you can use for that purpose. So you have to screen. And if you get a positive, you have to know, how bad is it? Do they have plan? Do they have intent? Do they have means? And so then you're doing this sort of tiered evaluation. Is it low risk? The kid that I described before, that I just wish I didn't have to think about this stuff. Is it imminent risk? Those are fairly straightforward. The imminent risk, that's going to the emergency room. The lower risk, I'm going to follow up. They might need some therapy. I'm going to keep my eyes on that kid because that is a risk. But it's those kids in the middle. And that's where I think you can do close follow-up, coordinated care with a therapist, and doing safety planning and lethal means assessment. You have to do lethal means assessment for any kid who has any level of suicidal ideation. You have to ask the question, do you have access to pills? Do you have access to firearms? Hanging is a hard one, because how do you restrict means when you can hang yourself with lots of different things? But if that's what their method is that they're thinking about, now you got to have eyes on in a different way.
Right. Let's go back to the screening for just a minute.
Sure.
Screening who? Screening every single visit, screening at well visits, screening at mental health visits?
Well, if you look at the recommendations, it says universal screening. Now, I've had the conversation about what that means. So at minimum, it should be universal screening at annual visits. And I think it absolutely should be any kid who has any kind of mental health, behavioral health concern. So that would include, your ADHD kids you're treating for anxiety, depression. Anytime you're in seeing them, you should be asking the question. The other group of kids are probably those with complex medical conditions. If you ask the researcher, they would say, ask every kid every time.
Right. That's what they said in your podcast.
and that's a hard, and
that's a lot.
And that's hard. And I get that. Are you going to ask the kid who comes in for a wart, are you having thoughts of suicide? It may be that kid is, and that you could make a difference, but I think you have to start somewhere.
Right.
So if you're not doing it routinely at annual visits, start there and certainly with your mental health patients. For sure.
I want to talk for a minute. This really is geared towards what I call regular people, even though this particular episode, I'm going to really encourage as many physicians to listen to. So we're kind of talking a little bit more than I usually do about this, podcast to physicians and other healthcare professionals. But let's talk to the parents right now.
Yeah.
I'm sure they'll have concerns. How can we give our kids ideas? How can we give them the screen?
Well, the thing that I would reassure parents is that asking about thoughts of suicide does not make kids suicidal. There's research. I want to say there's like 4 studies that looked at that very concern, because it's a reasonable concern. You're not going to make somebody suicidal by asking them. I think there's ways of asking. Parents have an innate sense of something's up with my kid. Many times parents downplay the risks of suicide, because who wants to go there? Who wants to think like, oh gosh, that couldn't be my kid. But I think that there are ways to ask, like, hey, you seem really down. I know when other kids are in that situation, sometimes they have thoughts of killing themselves. Have you ever thought about that? Worst case scenario, the kid's furious with you and doesn't want to talk to you. But you know what? Better that you asked than missed it. So I think that there are ways to ask that and be concerned and have conversations, but you're not going to make them suicidal by us asking that question, or you.
Right. Are there resources for parents to have these conversations?
Yeah, I think if you go on to the NIMH website, the National Institute of Mental Health, the Ask screener. There's also the AAP Blueprint for Youth Suicide Prevention has information on there. I'll have to look up some other resources. The other place to go is always for a lot of kids for questions is the healthychildren.org. The AAP's website for all things kids, and there's great information on there. So there's lots of resources for parents.
That's really, really good to know. Let's talk about prevention. One will be asking, right, whether the healthcare professional does, or even whether the parent does. That's one thing.
Yep.
What else could we do?
I think just being attuned to what's going on with your kid. Sleep. Is your child sleeping well? If they're not sleeping well, are they having trouble falling asleep, staying asleep? Sleep disturbances often coexist with mental health disorders and can make any kind of mood disorder worse. I mean, think about when you're exhausted. I mean, you're not your best self, right? Irritability can often is a masquerade for depression. You can all think about our crabby kids and think, oh, that's just normal, but it's really not a normal state. I mean, kids may have times when they are, but to have sustained irritability is not a normal state. Changes in performance, a drop in kids' grades, and loss of wanting to do things that they typically would do. Kids' jobs is individuation and wanting to be with their friends. Now, again, some kids that are maybe neuroatypical, that may be a little bit different in terms of what their friend circles look like, but people tend to want to be with other people and find joy in relationships. So if that changes, or, like the kid who always wanted to play sports and now they don't want to do that anymore. They don't want to do theater, whatever it was they were interested in. They're not engaging with the family. They're holed up in their room. Those are the kids. And certainly if they're writing about things online, you hear things from their friends. I mean, you certainly hear about these kids that have been engaged in these mass shooting violence. Those kids often had significant disturbance in mood and ideation about what they were thinking about. And there's a fine line between, those kids that are having thoughts of hurting others and having thoughts of hurting themselves. Those may go hand in hand. It's certainly not to say that every kid who has suicidal thoughts has homicidal thoughts, but often kids who have homicidal thoughts have suicidal thoughts as well.
Right. I mean, I think the bigger picture is this doesn't come out of thin air. Right.
No, I mean, it's not like one thing. There can be a triggering event, but usually it's on top of other stuff. There was a great program. It was called, I want to say, A Million Little Things. And it was about
13 things.
No, it was a program about adult men. And one of the men dies by suicide, but it was called A Million Little Things. And it really is about that. It's a bunch of stuff. It's not usually one thing, but it was an interesting show. But that I like the title of that because I think it encapsulates about suicide, what surrounds it.
Right. Because there was a controversial show.
Oh, the 13 Reasons Why.
The 13 Reasons Why. And I think that may be what's making some people think if we talk about it, we'll encourage it.
Right. Well, and 13 Reasons Why. And I'll be honest, I did not watch that, but
either.
It really glorified suicide. It talked about kind of vengeance. And I think when there has been a suicide, media needs to be careful about how it's reported. You don't want to be talking about the graphics of what happened. It's hard with social media now because, the information gets out, but every time there's a celebrity suicide, the suicide numbers go up. So there is this contagion kind of thing that can happen.
Right. But that shouldn't be confused with talking about it. In fact, the opposite is true.
Exactly.
It's kind of like sex education. If you don't talk to your kids, they will learn from the street. If you don't talk about these mental health concerns.
Well, and I think it's different talking about sort of the glorification about why someone died by, sort of a martyrdom kind of thing, as opposed to this person was really struggling. Are you struggling? Have you ever had thoughts like that? I think it's a teaching point.
Right. And, not everybody's going to be comfortable talking about this.
It took me a really long time to say the words, are you having thoughts of killing yourself? I used to say, do you ever wish you weren't here anymore? Well, kids sitting in my office, of course, they don't want to be here. They don't want to be in my office. So it was a misleading question.
Right.
So to say, are you having thoughts of suicide? Are you having thoughts of killing yourself? You're specifically asking what you want to know. But it's hard. It's hard to use the language. It's uncomfortable. But as a mom said, Ann Moss Rogers, who lost her son to suicide, she did an interview with me last year, and she said, you need to get comfortable being uncomfortable because you need to ask the question. I thought that was a beautiful way to put it.
It really is. I'm thinking of it in two different ways. I'm thinking of it, what you were talking before, more like the pediatrician hat on. It's hard for me as a pediatrician to talk about this. It's a really difficult topic. But I was actually thinking about the parents having a hard time talking about it.
Absolutely. And I do think you can kind of couch it in, I don't know about you, but I know other kids sometimes are thinking about, have had thoughts of killing themselves when, they're not doing well in school, or when they've had a big blow up with a friend, or they've been bullied. Are you having those thoughts? And I think that's maybe a little bit easier way to ask it. And sometimes people get mad. I asked a family member one time, she was furious with me. And I thought, you know what? I'd rather that you be angry with me than you have hurt yourself and or tried to kill yourself. So, you'll get over it. And she did. But I needed to ask.
Yeah, I actually have a question about that. When you do screening for suicidality, do you approach the parent first, or do you just ask the child? Do you tell the parent, I'm going to be asking your child questions about this? Is it okay with you?
No, I just say that we have routine screens. These are the screens that we do. So we just do them. And we ask, I ask the question, or, my MA gives them the screen, or they, a lot of places now they're doing iPads and they're doing screens. Sometimes they're doing through portals, which has a little bit of risk. If they do identify suicidal ideation on a portal, you have to have a disclaimer on there that somebody's not looking at this 24/7. And if you're having thoughts, please call 911. So there's a caveat with that.
Oh, wow. But you haven't had parents get upset. I did not know you were going to ask my child this question.
I've never had anybody question me about that.
Interesting. Again, we went through it already, how important it is, but not everybody understands that talking about it will make it less likely, not more likely.
I think that I would explain it as a safety thing, and I think you could share, suicide is the second reason why kids die. It's recommended that we screen all kids because we don't know by looking, and we would never want to miss someone. So we ask all our kids as a routine part, just like we do a blood pressure, we ask about suicidal thoughts.
Right. And how young do you screen them?
We screen them 12 and up.
Okay.
So that was the initial recommendations from the United States Prevention Task Force Services. Some places will say 11. The developer of the ASQ says 10. So I think at least at 12, you can go younger though. And if you have kids that you're treating for mental health concerns, you can use the screen actually down to kids even age 8. The Ask Suicide Screening Questionnaire.
Right, but you wouldn't be routinely screening an 8 or 9-year-old.
No. And there's not really good evidence for that young. There's no recommendations for that as a routine. But I've had kids that are 9 years old. They're telling their parents, I'm going to jump off the house. And so it's a nice format to be able to say, your mom said you're thinking about jumping off the house. Are you having thoughts of killing yourself? Have you ever wished that you could kill yourself, or, so you could go through the questionnaire, and it gives you the language to do that, which is why I like these screeners, because they're scripted. So you don't have to mess around with finding the right words. The words are there for you.
Right. Are you asking, or are you giving a paper screen?
We do both. It depends. In a situation, the 9-year-old that I'm thinking of, I asked him, and the mom was actually in the room. Some people would recommend that the parents step out.
Right.
And sometimes I'll have the parent, can I talk to your child for just a minute? There's a couple things I want to go over. But I always want to make, partner up with the kids. And I would never tell a kid, I'm not going to tell your mom. I tell them, this is something I need to share with your mom. You can give them some locus of control by saying, would you like me to tell your mom what you're thinking about? Do you want to do it together? How would you like us to do that? And oftentimes they'll say, could you tell my mom first?
Right. I always have the disclaimer that everything we talk about together is confidential, except if you're going to hurt yourself or someone else.
Yeah. Or, someone's hurting you, so when it comes to safety, I need to talk to your parent or caregiver, And sometimes, if they're in an unsafe situation, then you have to think about that a little bit. But that again is not as common. So.
Right. So back to the parent who says, okay, I know this is important. I really don't feel comfortable talking about this. They're worried about their child. What could they do?
So that they're worried about their child in terms of
they're worried. They see some of the signs.
Mhm.
So what could they do? They don't really feel comfortable having the conversation themselves. They're worried that their child is showing some signs of possible depression, possible anxiety, all those things you talked about before. They're more isolated.
Sure. Well, I think first off is, you can say to the child, hey, I've noticed that, you haven't been wanting to see your friends. You haven't been wanting to hang out with the family at dinner time. What's up? What's going on? And you can just start. You don't have to start right away with suicide, but what's going on, and be open to listening, and having that conversation about, being curious about what's going on in their life. I think a lot of times we don't want to hear it. It's too hard. It feels like, how could that possibly be? I'm trying so hard to be a good parent. How could this happen to me? I thought about that with my daughter with her eating disorder. I just didn't know. I'm a physician. How did I miss that? But, I think you have to give yourself grace that, things happen and you don't always know.
Right. Being a mother is different than being a physician. What I was thinking, though, is that you can bring your child to your child's pediatrician or other healthcare professional and say, I need your help with this. I'm uncomfortable. I'm worried. It is appropriate. I see kids all the time. I get phone calls and I see kids all the time for this. We do this.
Yeah. And I think that that's certainly acceptable to have, call your pediatric office, your family practice, whoever you see regularly, and just say, hey, these are the things I'm seeing in my child, and can I bring them in?
Right. And tell them I'm going to need extra time.
Yes, absolutely. Yeah. That's a big kicker, isn't it? And a lot of times
the same appointment is for a strep throat, and this will not take that amount of time.
And I think that's something you can do to help train your staff.
Right.
Is, do you need, I think, and that's something, if I was doing an assessment of an office, I would want to know, how do you assess your behavioral health patients? Does your MA staff, do they know what questions to ask? Just to get a little bit of information so they know how much time you need.
Right. No, absolutely. It's really, really important.
Yeah.
So what other tips would you give? We talked about parents. We talked about pediatricians, other HCPs, healthcare professionals. What about teachers? This must come up for them as well.
Oh, I think it happens a lot, and they're often out of the loop. Kids who are in inpatient psychiatric hospitals for suicidal ideation, unless the parent gives permission, the school may not know. And so these kids are at school. So, but I think teachers can ask these questions too. And I think you can couch it in the same, hey, I'm really worried about you. What's going on? Because a kid may tell a teacher, a trusted coach, if they know that you really care about them, you can ask these questions. And, these questionnaires are not specific to being a mental health professional. Right. The Columbia was designed for first responders. So, asking the question about, I'm worried about you. Are you having thoughts that, are you having thoughts of killing yourself? Gosh, if you're the one that finds that, but you also have to have a plan at your school about what do you do with these kids. But, they're in all of our environments. And I think as a system, you have to have healthcare, schools, and mental health. And it's like the three sides of the triangle. And any one of those alone, it falls apart.
Right. It's really hard, though, because of that confidentiality.
Yeah.
As a pediatrician, I can find out about my kids, appendicitis operation, but I can't find out about their psych hospitalization without going through a bunch of hoops. It's
right. And with the schools, it's called FERPA. And with us, medical folks, it's called HIPAA. And then mental health has their own even tighter regulations. So, right. But I think where parents can help with that is to give permission for schools to talk to the doctor, for the doctor to talk to the school and the therapist, because it's not stigmatizing your child. Right. It's like, how do we bring people into the safety net for your kid? And honestly,
Absolutely.
when I've asked that to parent, I've never had a parent say, you can't call the school. I've had kids that have said, I don't want you to talk to my teachers. And then is there a teacher? Is there someone? Michigan's working on an interesting thing. It's called the Behavioral Health Learning Collaborative. And it's using something called, or BH Works. It's using something called MD Logics. And it's essentially an electronic health record for the schools where they can share information about screening. They'll do mental health screening, and they can, so that if a psychologist is seeing the kid, that they can access these screens. And they can loop in mental health. They can loop in primary care with permission. I mean, you can't do it. So I think it's an interesting project. It's they've placed it in several of our intermediate school districts and are hoping to expand it to the entire state. So we got big funding to do that. I think it's an interesting, I'm part of that group because I keep saying, please make sure that primary care is in this as well.
Right. I mean, I've seen here that we have collaborations between mental health and school, but the physician is not looped in.
Right. And I think, to be fair, it's hard, a teacher's busy and they're seeing kids and to try and call you the doctor. But man, when I've had those conversations with a teacher, I mean, it doesn't have to be about suicide, but a kid with ADHD, if I can ask them, what are you seeing? Well, what they're seeing may be very different than what the parent's seeing. And that information's invaluable. So those conversations need to be happening.
Absolutely. And when I do get involved, I get, oh my gosh, you're the first pediatrician I've spoken to ever.
They're so excited.
They're so happy. They're so thrilled. It's like you said, 3 parts to the triangle. We got to get those to connect.
Yep.
So that's exciting to hear what's going on in Michigan. We got to pick up the ball here in New York.
One of my favorite lines from the Zero Suicide Institute is that suicide prevention is not the heroic efforts of a single individual.
Right.
It's about a team. So, I mean, it's all well and good for me to ask the question, but I can't do it alone. So that's why, having a framework to do that. And here's a shout out to Zero Suicide. I'm on faculty for Zero Suicide. And if you have a big organization and you want to do kind of suicide prevention big time, you can sign up for an academy. It's a 2-day, and it's an intensive how to implement suicide prevention. It was based on something they did at Henry Ford Health System back in I want to say 2004. But the zerosuicide.org site, I mean, there is so much stuff on there about kind of a system change. And it starts with leadership. So for those of you that are healthcare providers, it starts with you. You have to make the commitment that we need to do something different in our practice. And then it goes down through, there's 7 elements. Training is the absolute so important. It has to be everybody. Like, I don't know about you, but when the PHQ, I never had anybody train me on that. We just started using it.
Right.
I mean, I knew what to do with it for me, but we didn't talk about it as a group. And it wasn't that we were doing something bad. It's just, we could have done so much better. So training, and that gets everybody's buy-in, from the front office to the physicians. Like, does everybody know what this tool is and why are we doing it? Because then they're all part of the plan. So there's training. Identification is doing the screening, engagement. That would be sort of safety planning. Treatment is really not what we're doing. And then transition, that moving from place to place. So if I'm going to send a kid to the emergency room, I need to call the emergency room. We need to have that loop, of care, that sort of warm handoff. And then improve, which is basically you need to look at, what's your data? Are you making an improvement? So think about it as a kind of a QI project.
Right. That's so important. Is that organization for healthcare professionals only?
Zerosuicide.org was developed for behavioral health and for healthcare, primary care, healthcare, emergency rooms. Not so much school-based or community-based, but it started out in a behavioral health practice. But yeah, go to the website. There's so much stuff on there. The other thing I would tell, if you're a healthcare provider, take the CALM course, Counseling Access to Lethal Means. If you Google CALM and suicide prevention, it's about a 2-hour training. It's free. It is so helpful. I mean, just calm course, do it. You need to know how to ask about lethal means.
Right. And if you're listening to this and you're a parent and not a healthcare professional, but you want your pediatric office to do this, you can share this podcast with them.
Yep. And if you're a parent and you want to know about how do people ask these questions, you can go to, it's called the Lighthouse Project, the Columbia Lighthouse Project. And they have a video of a first responder. Now, these is with an adult, but they have a first responder asking the questions of somebody who's standing near the edge of a bridge. So you can actually hear what it's like to ask the questions. There's also a really nice, I'll send you the link. Mayo Clinic has a really nice, it's like a 1-minute video of kids basically saying, just ask, ask us, please ask.
You said Lighthouse, and there's another organization. I think it's called Erica's Lighthouse. Have you heard of this one?
Nope, that is not familiar to me.
I'm pretty sure it's called Erica's Lighthouse. Yes. It's a not-for-profit organization that was actually named after a child who died by suicide named Erica. I think she was 14. And that's Erica with a K. It's Lighthouse. So I had to bring up that organization too. I actually spoke to the organizers of that, people on the board.
Well, and the other is if you are the parent of a child and who identifies as LGBTQ, the Trevor Project has lots of resources for kids in that population. The other thing, just to mention, I noticed something you said, and I would encourage others to use the terminology of died by suicide as opposed to commit suicide. Right. And that it was a suicide attempt as opposed to a successful attempt or unsuccessful attempt. So I think that words matter, and those are important.
Really does. Absolutely.
And it takes a little bit of doing. It took a while for me to be able to say died by suicide. It sounded
Sounds
clunky
weird at first.
But now when I hear somebody say committed suicide, I cringe.
Yeah. You're blaming the victim.
Yeah.
That's important. I'm glad you said that. I'm really glad you said that. So again, the reason I'm pointing this out for people who are listening who are not healthcare professionals is, say you're listening to, like, my pediatrician doesn't do this. My office, that I might take my child to doesn't do this. Could I do something about it? There are all these organizations, or you can get some of the tips from this and bring them to that practice. And then you can make a difference for lots of kids.
Well, you could say, hey, I heard that there's something called Bright Futures that pediatricians follow that says that pediatricians need to screen for suicide. Are you guys doing that?
Right.
I think many, it seems like a big majority of pediatricians are screening for depression.
Right.
But I think this is just the next step. And again, that question number 9 on the PHQ-9, if people look at it, it is a proxy. I mean, it does ask, it kind of starts to get at it, but I think you can be more specific using one of the other tools along with the PHQ-9.
Right. And a common fear, by the way, is, well, what if I pick this up? Then what do I do with it?
Well, exactly. And that's where you can go on to the AAP's blueprint for youth suicide prevention. And there's a whole clinical pathway, and it talks about what you need to do. The first recommendation is figure out what are your resources in your community. Who are you going to partner up with, and how are you going to do that? That's the first thing. And then I think the other thing is sitting down with your partners and your staff and talk about, hey, we need to do this. Where do we need to start? Right. And if you want to email me, GagginoL@medicalBHS.com, I'd be happy to help.
Right. And I'm going to mention that at least one more time. I told you I would. No, it's really, really important. This is called, if you save one life, it's from the Talmudic dictum. If you save one life, then you save the world.
Yeah. Yeah.
And again, we can all do this. It has to be a team approach. The mental health issues we're struggling with are vast.
Yeah. I like the starfish analogy about the starfish that are getting washed up, and then, the kids holding the one starfish and they're like, oh, it's just one, but it's like, yeah, but this is one starfish. It matters to this one.
Yes, that's one of my favorites.
The other comment that I had from a PA that I interviewed, Dustin, and what he said, I loved it. He said, it's not about the ones that we catch, it's the ones we would have missed, and those are the ones and the thing is, just think about the reward of finding out that there was a kid that was having those kinds of scary thoughts, and you're like, hey, let me help you out of the hole.
Right.
And what a life, you've changed a life, a community, a family. I mean, It's not just the kid, and it's all their potential.
Right. It really is the entire change of perspective to look at it. No, I have to worry about the ones I will miss. And that's exactly true. It's like the monkey with the hands on the face and the hands on the ears. I'd rather not know about it.
Right. Well, and I do think, to be fair to clinicians, is this stuff does take time. There is no question.
Right.
And so I think, can you have a conversation with your partners about how do we tag team each other when I've got a really serious case like this? And this is, again, a case for if you have, we had social work in our practice. I could ask my social worker to step in and do the risk assessment, do the safety plan, and then I could move on to the next patient and then circle back. So whatever you can do to figure that out, do it. It's worth every penny. You won't be sorry. Right. You're going to wonder how you function without it.
Right. But this idea that you would have some kind of liability for picking it up, it's the opposite.
Yeah.
Right.
Well, and I've heard a defense attorney on 2 occasions talk about liability and suicidality. And what he said is, if I'm reviewing the chart of a patient who died by suicide for a family, and I see that there was an evidence-based screening tool used, an evidence-based risk assessment tool, a safety plan, that they counseled access to lethal means safety. He said, I don't pursue those cases because everything was done that could be done.
Right.
And so they weren't negligent. So you're in better shape if you have those processes in place rather than just ignoring it or letting it go or saying, I'll, go see a therapist, because we know, 70 to 80% of people don't go when you recommend that they go to therapy. And if they go, they go like 4 times max.
Right.
So, that idea that we can just pass it off to therapy, you need to be the one that says, how can I help?
Right. But you're also not in control of the outcome.
No. And again, there's no guarantee. I liken it to, someone goes into the emergency room with a cardiac arrest or what they presume might be, and they do the big workup and all the tests come back negative and the patient leaves. They did all the appropriate things. Could they still have a heart attack? Yeah. So there's no guarantees. We're not magicians, but you've done the highest level of care. And I think that's the point.
You did what you could do.
Yeah.
Right. So I think that's really important. So I just want to mention, this is being recorded in June, but this is really, to me, very exciting news that as of July 16th, so by the time this is out there, it should be out already, there will be a 3-number hotline for prevention of suicide, for people to call in with suicidal, ideation, thoughts of suicide, plans. It's 988.
Yes. Isn't that great? Because I have to always
I can never remember the other number. I cannot remember it.
The other thing, so there's a couple tips that I would give to clinicians and parents too, is when you see a patient for a well visit, regardless of whether they're having difficulties, is have them put those phone numbers in their phone, the 988 and the crisis text, which is 741-741. And, the thing that you can tell them is, hey, I just want you to have this information. If you ever have a friend who's having difficulty, and it doesn't have to be suicide, you're just having a tough time, you can text 741-741 help. You can put ayuda, AYUDA, if you're Spanish speaking, and you get a Spanish speaking person on the line, and they can text back and forth with you. So the crisis text, I think, is brilliant, but the 988 is awesome. And every clinician should be giving that information to patients when you are concerned about, any possibility of suicide.
It's really, really important. So we have so much more that we could be talking about, but I'm going to let you go. But
I did want to underscore one more thing.
Okay, sure.
And that's firearm safety.
Yes.
Parents, if you're a parent and you have a firearm, please store it in a locked safe with the ammunition stored and locked separately. Ideally, if you have a child that has mental health concerns, remove the gun from the home. parents underestimate that kids know how to get into these firearms, and they do. They can figure it out. So the safest is the gun out of the home, but at minimum, the firearm needs to be secured. And oftentimes the kids do know how to get to that. And even if they would never think about a gun, lock them up anyway. And they should always be locked and secured, regardless of whether you have a concern about mental health. Guns are killing little kids, or getting into them. A 2-year-old can pull a trigger, and that's terrifying.
Absolutely true. It's absolutely true. I'm glad you said that. And it can't
I hate to end with that, because
I know this is such a hard topic. It's such a hard topic, but you know what? Sometimes you just have to do it. Like you said, we have to be get uncomfortable with being, how did you say it?
Be comfortable with being uncomfortable.
Or even be uncomfortable with being comfortable, but just do it, because we have to.
Yeah, we got to ask these hard questions.
We have to talk about it. We have
to remember, this is what's killing kids.
Right. And get the gun out of the house if your child is having these issues. Forget about all the safety things. Just get rid of it.
Absolutely.
It's easy for us to say. I know people are very, passionate about this. But
I've had those hard conversations, and I just say, I don't want to be the one coming to your child's funeral.
Right.
And you will never get over if they use your gun to kill themselves. So for the time being, your child isn't thinking straight right now. Their brain is not functioning normally. I know you think they would never do that, but they're not thinking clearly. So for the time being, remove the gun from the home. And how can I help you figure out how to do that? What strategies? And that's where the CALM course is really helpful, because it goes through that motivational interviewing strategy about how to talk with somebody who's resistant to that.
Absolutely.
But focus on the safety.
Focus on the safety, and underscore again that, if you're a parent and you have concerns, go get help. Yeah. It doesn't have to be on the level of you think your child is having suicidal thoughts. You just see something, then say something. And for physicians to be taking the time to go through this with families and be there for them.
Well, and I think by us asking these questions, it normalizes it for kids, that this is something that, I'm not depressed now, and I'm not having thoughts of suicide now, but I know Dr. Gaggino, if I told her that in 6 months, that it would be okay with her to talk about it. She's not afraid to hear. Right.
I like to say, I care about your mental health at least as much as I care about your physical health.
Yeah. I care about you.
I care about you, and you is a lot of pieces, right?
Well, and that's why patients come to us and families come to us, because they know that we care about them. So that's really important. That's probably the most important thing you do, is convey care.
It's so true. It really is. Yeah. I want to end. I'm giving your line back that you say every single time. I want to end with this. And first of all, I want to thank you so much for doing this with me. It was so important. Fun. Yes. Well, it's a difficult topic. But I did like doing it with you. But I want to end with Maya Angelou. I never get tired of hearing you quote her line, the poet and writer, Maya Angelou. Do the best you can until you know better. Then when you know better, do better. And we can all do better. And I think you gave us a lot of tools and tips, and you get one more chance to plug you.
Yep. So check out my website, www.medicalbhs, B like boy, hs.com. So it's Behavioral Health Solutions. I'm happy if you want to email me, if you've got questions about how you can up your game in your office. I would love to talk with you about that. And I know, that you'll share lots of web links and things like that in your show notes. So check there for the information.
Yeah, send them to me, please.
I will do that.
Awesome. And also your podcast, Pediatric Meltdown. I know that you say it's for physicians, pediatricians. It really can be listened to by a wide range of people. And it is so good. So thank you.
It is a blast. I love it. I'm so fortunate to have been able to talk with so many really tremendous people, physicians, pediatricians, psychiatrists, teachers, mental health professionals. I'm interviewing a mom tomorrow, one of my former patients' moms. I've interviewed some patients who are now all grown up. So there's something there for everyone.
Yep.
And it's just been a fun project for me.
No, I'm with you. I love it. I learned so much, and I learned a lot from you today. So I'm excited to share it.
Thank you for asking me. I appreciate the time.
Thank you so much.
Thanks for listening to the JOMA Preventative Health Podcast. If you've enjoyed this, please rate and review us on Apple Podcasts and share this with your friends. For more information, check out our Instagram at JOMA_org. Check out our website, www.joma.org, that's JOWMA.org, or email us at health@joma.org.